Hello everyone, Master Dr. Mangesh. Today I am going to discuss on the topic pneumoperitoneum, which is frequently asked during practical exams. Gas is the body's own natural contrast medium, much of which is swallowed, and its appearance as the darkest density appearing on the X-ray films should now be familiar to you, especially in the abdomen as well as the chest. But most importantly, from the diagnostic viewpoint, owing to the variety of the pathological process, gas may escape from the lumen of the gut into the peritoneal cavity as well as into the retroperitoneal space. Let's discuss pneumoperitoneum. It is diagnosed by the presence of the bilateral dark crescents of the gas under both hemidiaphragm. This is a large pneumoperitoneum, but small amount of the gas requires time to rise to the subdiaphragmatic position. So it is a good idea to leave the patient upright for 10 minutes to allow this to happen before taking the X-ray. With attention to the details, as little as 1 ml of the free gas may be demonstrated, or patient lie on his left side allowing gas to rise to the right side. There are some signs of the free gas in the peritoneal cavity as discussed here. The example is the double wall sign or the regular sign, that is, both sides of the wall of the loops of the bowel become visible because of the gas on the inside and gas on the outside. Try to find such an isolated viscous such as the stomach or the bowel loop. But remember that closely opposed loops may give a false positive double wall sign when back to back. Let's discuss the causes of the pneumoperitoneum. The causes are categorized in two, that is with peritonitis and without peritonitis. Let's see what are the causes with peritonitis. Perforated peptic ulcer, stomach or duodenum, intestinal obstruction, ruptured diarrheal disease, although this most remains localized, blunt trauma with tearing of gut, penetrating injury as seen in gunshot, knife wounds, etc. Ruptured inflammatory bowel disease, example in megacolon, colonic infection as in typhoid, steroids and NSAIDs. Let's see what are the causes without peritonitis, post-laparotomy and post-laparoscopy. In these two conditions, the gas beneath the diaphragm disappears within 7 to 10 days. Other causes are jejunal diverticulosis, steroids, cracking from the chest, peritoneal dialysis, vaginal insufflation, pneumonitis coli. There are some misleading phenomena. Many important phenomena can simulate a pneumoperitoneum and can lead to misdiagnosis and unnecessary surgery, with all its medical and medico-legal implications. A good selection of this is shown to emphasize their crucial importance. Linear atelectasis. It is a phenomenon that occurs in the lungs, usually at the bases. It is frequently associated with infection or pulmonary embolism and is commonly seen after anesthetics in the postoperative phase. It forms dense horizontal or curved bands which may simulate the diaphragm. Normally, it resolves within days or weeks, but may persist for longer. Nothing has to be done to the abdomen. The other cause is the chilidated syndrome. This incidental finding of pocket of the gas beneath the right hemidiaphragm, multiple bands of the mucosal folds indicating the gut may be seen. This is a colonic interposition and abdominal film showed continuity with the rest of the colon. Conversely, after an iatrogenic procedure such as endoscopy, extraluminal gas should not be expected, and its presence in that situation indicate a catastrophe, that is, perforation of the gut, and the procedure need not have been technically difficult for this to occur. With this, we come to an end. Thank you. Please share this video.